Welcome to this PVI webinar sponsored by Gore. We will focus this evening on complex aortic repairs and bridging stents. I'm Stéphan Haulon, I'm one of the Paris Vascular Insights course co-director together with Koen Delouz, Jan Guefik and Eric Ducasse. I am very happy to host this webinar. More than 400 of you are registered. During the webinar, you can ask questions and I'll have direct access to those questions and ask the experts that have joined me tonight, which are Arjan Hoksbergen from Amsterdam. Good evening, Arjan.
Thank you.
Manuel Hernando Rydings from Madrid. Good evening, Manuel.
Good evening, Stéphan.
And Abisi from London. Welcome to Paris.
Good evening.
So this webinar will be on the PVI online, which is our website next week. So for those that will not be able to see it live, you can see it later on. It's time to jump into that webinar and start with Arjan that will talk about the real-world experience of VBX stent graft in complex aortic procedures. Arjan, the floor is yours.
Thank you, Stéphan, and thank you, PVI, for inviting me to this webinar in Paris. And I will show you the highlights from the important EXPAND and EMBRACE registries. As mentioned, my name is Arjan Hoksbergen. I'm a vascular surgeon in Amsterdam University Medical Centers. These are my relevant disclosures. The VBX stent has CE mark and FDA approval since 2017. And actually, it has the broadest range of on-label indications. And with this stent, more patients and different pathologies can be treated than with alternative products under the IFU. Since last summer, the VBX also has an indication as a bridging stent for fEVAR and bEVAR under the MDR. The VBX has independent stainless steel rings connected by the well-known fluoropolymer graft, which gives it flexibility and conformability. This construction minimizes foreshortening when post-dilated, and it provides a high radial strength. It has the heparin surface that we know from the Gore products, and it's mounted on a semi-compliant covered balloon, which has ePTFE stent fixation. And this results in that you will have to apply immense forces to get the stent off the balloon. You will not succeed, happily. You can undersize the VBX, but what is maybe more important is that you really can oversize the stent graft without damaging the integrity of the stent. A nice example of such a case is this patient with an acute pancreatitis and a rapidly growing aneurysm of the celiac trunk. And we had to do an urgent repair, and we used, for this specific case, the 8 large VBX stent graft. And the important feature of this specific stent is that you can post-dilate this all the way up to 16 millimeters, as you can see on the right-hand image. An example of the flexibility of the stent graft is this case. This is a regular bEVAR case. Where we inserted a VBX through an 8.5 French steerable sheath inside the left renal artery. And this was the 8.5 French sheath with the 17 millimeter radius. And even without a bowstring suture to keep the bend in the steerable sheath, we could insert the VBX inside the left renal without problems. Many studies have been published. These are all physician-initiated studies about fEVAR and bEVAR, but Gore also initiated a clinical program studying the real-world performance of the VBX. 2 important registries I will highlight. These are the EXPAND and the EMBRACE registries, with both more than 280 and 259 patients. The EXPAND registry was a registry where the VBX was used for multiple indications, and the EMBRACE registry was specifically designed to test the real-world performance in fEVAR, bEVAR cases only. The EXPAND registry was done between 2019 and 2022. This was a prospective multi-center observational registry evaluating the post-market safety and the performance of the VBX in a real-world setting. 15 European sites enrolled patients, and they enrolled a total of 280 patients with different pathologies. 112 cases were fEVAR and bEVAR, and the follow-up was 5 years. The 1-year results and the 3 years results of the bEVAR arm of this registry have been recently published in the Journal of Vascular Surgery, and the primary endpoints at 30 days were technical success and VBX-related serious adverse events. Secondary endpoints were patency of the stent, procedure-related serious adverse events, mortality, and device integrity. 73 patients in the bEVAR cohort with in total 223 target vessels. And what is important is that the 30-day composite of procedural success and freedom from serious adverse events was 98.6%. Most of the aneurysms were thoracoabdominals. 3 years results of this cohort show a target vessel primary and secondary patency of 93.6% and 96.8% respectively. And when we look at the freedom from target vessel instability, this was 94.5% after 3 years in this bEVAR cohort. When we look at the fEVAR cohorts, 39 patients were included with in total 97 target vessels. Most of the aneurysms were pararenal, and most patients had 1 VBX per target vessel. The procedural success and freedom from related serious adverse events was 100%. Target vessel primary and secondary patency were 96.5% and a staggering 100% after 3 years. Freedom from target vessel instability after 3 years was 96.5% after 3 years. When we go to the EMBRACE registry, again, this was a multi-center, single-arm, retrospective and prospective registry. Patients treated with the VBX as a bridging stent for bEVAR and fEVAR only were included, and the primary objective was to confirm the clinical performance and safety of the VBX. In total, 259 subjects in 14 European sites were enrolled, and the enrollment was completed in 2024. Again, this registry has a follow-up of 5 years. Primary endpoints were target vessel patency at 1 year, and secondary endpoints were major adverse events, technical success of the whole EVAR procedure, patency, instability, reinterventions, and aneurysm-related mortality at 1 year and annually. And when we look at the primary patency in the bEVAR cohort, in this cohort there were 165 patients with a total of 454 target vessels. The primary patency of the 1 year was almost 99%. And interestingly enough, there was no difference or hardly any difference between the primary patency in the celiac and the SMA compared to the renal arteries. Freedom from target vessel instability in the bEVAR group was 94.5%, and the events contributing to the vessel instability were mainly endoleaks type 1C, and some were 3C. When we look at the fEVAR cohort, this was a cohort of 103 patients with 208 target vessels included. Primary patency was almost 100% after 1 year, and there was only 1% difference between the patency of the celiac and SMA compared to the renal arteries. These results were presented at the last Paris Vascular Insight course in Paris. Freedom from target vessel instability in the fEVAR group was 96.6%, and the events contributing to this instability were also mainly endoleaks. Occlusions were rare, and all endoleaks were type 3C, so at the level of the main body of the endograft. These are our own results from Amsterdam. Target vessel instability at 1 year in 254 target vessels in 84 patients. This was 98.1% in fenestrated procedures and 79.5% in branched procedures after 1 year. Well, to conclude, these results from the EXPAND, the 3-year results from the EXPAND and the 1-year result from the EMBRACE, show a very high technical success of the VBX procedure. The primary patency is relatively high, with fEVAR even a little bit higher than in bEVAR cases, and the freedom from target vessel instability is also quite high, with the fEVAR cases a little bit higher than the bEVAR cases. And the results from the EMBRACE, the both arms, the fEVAR and the bEVAR arms are now submitted for publication. Thank you.
Thank you very much, Arjan. That was a great overview of the available literature with a specific focus on EXPAND and EMBRACE. I mean, we can see that there is a high level of evidence here published with those registries. You know the literature on complex aortic repairs and bridging stents. How do you look at the data you've just showed? Is it relevant compared to the available literature?
Well, there's an abundance of literature about VBX and fEVAR and bEVAR. Usually this is all single center data. And in my experience, the result, and we also see this in our own cohort, are the results of single center studies even better than the real world evidence, as I showed you from these registries. Because in these registries are not only hospitals included who only use this VBX or as a workhorse, but there are also hospitals included in the registry who normally use other types of bridging stents and or use this VBX as a bailout stent graft. So typically the results, what I see in the literature and what I said when I compared it to our own results is that they tend to be even a little bit better than these results, which are already quite good, I must say.
Manuel and Said, do you have any questions for Arjan?
No, it's a very impressive outcome, and I think, as you said, the real-world data, when you look at the type 1C, make us aware that placement of the bridging stent in bEVAR is most important. What's your recommendation of the amount of overlap for the bridging stent VBX and bEVAR specifically? Would you say 15 or 20 millimeter?
In the IFU, it's 20 millimeters. And I think that is wise. It's not wise to go below that 20 millimeters. You definitely have a higher chance of a 1C endoleak. So I think this 2 centimeter is really well thought and good in the IFU. Yeah. And what we see from the physician-initiated studies from the beginning, they all recommend this 2 centimeters of overlap in the target vessel when you do bEVAR. Yeah, they learned from their 1C endoleaks.
Yeah. Manuel?
Yes, well, very strong data, interesting information regarding the VBX in branches. And in our center, we also go for 20 millimeters inside the target vessel. I think it's the good thing to do.
Yeah.
Okay.
Yeah.
And regarding the 20 millimeter length, and regarding oversizing or undersizing, or how do you tackle? How do you want to make sure you have it?
Oversizing, I tend to oversize, but only with 1 millimeter. But 1 millimeter in a 10 millimeter vessel is, of course, more than in a 6 millimeter vessel. So that is a difficult issue. In small vessels, in really small renals, for example, 4 or 5 millimeters, I'm very careful in oversizing too much. And the nice thing of the VBX that you can insert, for example, a 6 millimeter VBX and undersize it. So you deploy the balloon so that the VBX will be 5 millimeters at the end of the stent graft, which is a nice feature, I guess.
Yeah, and
So you can play a little bit with the diameter of the stent graft. You can, at the end, you can undersize it, and inside the main graft, you can dilate it further as you want or as you like.
And it's probably safer to slightly undersize, and if you have a leak, it's not a big deal to go back
To go back and to balloon it
Exactly.
again, yes.
Because it's during the same procedure.
Yeah.
Well, thank you so much for sharing your experience, Arjan, and your expertise. Can I remind you that if you have any questions, please send them to us, and I can ask the experts that are with me in the studio in Paris. We're going to now switch to Manuel, who will talk about tips and tricks, and more specifically about the versatility in practice, technical considerations of VBX as a bridging stent graft in the fenestrating branch endovascular repair. So the floor is yours, Manuel.
Okay, well, thank you, Stéphan, for the kind invitation, Gore as well. Well, these are my disclosures. Well, in 2026, we know that complex aortic repairs do work well, but even nowadays, we also know that its weak point continues to be the reintervention rate. Although in this recent paper by Hoksbergen, the redo rate between endo and open was quite similar. We can see that in the endo group, it was most related or more related to target vessel problems. So one of the great questions we could ask ourselves is how we can reduce target vessel instability and hence improve long-term results. So now, during the next 10 minutes, I'm going to talk about how to choose the correct bridging stent in fEVAR, and just one tip when planning these cases, because of course not everything is just choosing one bridging stent or another. The same in bEVAR, and finally a couple of hints about our results. So starting from the beginning, when I was preparing these slides, I was thinking about how would I choose or my ideal characteristics when choosing one stent graft or another. And the first one, from my point of view, would be durability. So I want long-term results when I'm treating my patients. And interestingly, last week during critical issues, Austerman presented his fatigue study in which he compared 4 bridging stents. He used his in vitro simulation of cardiorespiratory cycles, and as you can see, after 100 million cycles, he saw that only bGraft Plus and BVX had no issues with fabric and no rust on the surface of the stents. And he analyzed the point of break of fabric as well, and as you can see, only bGraft Plus and BVX resisted above 100 million cycles. I would also like my stent to have a strong clinical evidence, as we just saw right now. If you check PubMed, during the last 3 years, more than 20 papers have been published regarding the use of BVX in fEVAR cases. Don't be worried, I'm just going to point out 2 of them. The first one from Dallas, 2-year results with 95% freedom from target vessel instability, which supports the feasibility, safety, and effectiveness of BVX in fEVAR cases. And the second one from Florence, 3 years results with almost 97% freedom from target vessel reinterventions, and a similar conclusion to Dallas. I would also like my stent to be precise, because when I'm planning these cases, I don't want to oversize. So I'm quite obsessed checking the numbers and the diameters and pressures and all of that, because I think that target vessel instability in one way or another is going to directly depend on the reliability of these tables. So if we undersize, we know what could happen, and if we oversize, we also know that we are increasing the risk of intimal damage. So this was an interesting paper in which they checked branch instability after final angiography using IVUS, and they saw an extra 12% of target vessel instability, which could be related to distal poor position of the bridging stent, related to, as I said, inaccuracy in achieving target diameter. So Uppsala published this paper, an in vitro assessment of the expansion rate of different balloon expandable stents with IVUS again, and they saw that VVX was the only one that could be expanded to its intended diameter at nominal pressure. And finally, the most important characteristic I think it's flexibility, because it's going to be related with patency. And when I was preparing this talk also with my hypothesis was that with a more flexible stent, maybe you would need less distal relining with an uncovered stent. So I also checked this, and if we check papers published about BVX, the most repeated word is, as you know, flexibility, flexible, so always appears. I'm not going to talk about its structure. It's true that at the beginning of the experience, we were not sure about the stability of this structure in fEVAR cases, but now we know that in fact it's a positive thing. This was beautifully explained in this paper by Jean-Paul Devry, in which he analyzed the stability of BVX in fEVAR with a good follow-up, and he saw that this stent was stable during the follow-up in fEVAR cases, except for the flare angle that changed during follow-up as a continued adaptation to target vessel anatomy. So from my point of view, if we choose a more flexible stent, we are going to adapt better to target vessel's anatomy. We are also going to adapt better to respiratory movements, and this is going to affect results. So we are going to reduce distal misalignment and improve patency rates. So I think that now we are moving from this kind of images when we use the stiffer stents to these kind of images in which you can see that the bending, the angulation of the bridging stent happens at the point of the fenestration and not at the distal end. So I believe this is the way to go and the only way to improve long-term results. If we talk about patency rates, I'm not going to repeat Embrace. This was confirmed at 3 years by Florence Group, 99%. And talking about the need of a distal uncovered stent, this is the information by Kolbel in this meta-analysis in bEVAR. So 14% of the cases needed an extra uncovered stent distally. In our experience, in the same cohort, the rate is just 5%. And if we check Embrace, it's just 1%. So I think this is the way to go, as I said. The planning bonus would be that please remind that now we have evidence which supports the use of small 6x6 fens, which in some way reduce target vessel instability during follow-up. And this is because we can achieve a more reflective fare using smaller balloons. In experience, using just balloons 2 millimeters wider than the bridging stent is more than enough. And we are also able to achieve a more stable and durable flare with increased pull-out forces during follow-up, just because the hull is smaller, so no rocket science here. If we talk about bEVAR, just 2 papers. The first one, this well-known paper by Odrik in 2020, in which he described a higher risk of target vessel instability in bEVAR using balloon expandable stents. This happened especially in renal arteries, not so in visceral arteries. So in Odrik's words, not in my words, because this is out of IFU, his technique has evolved to using self-expandable in renal artery branches. This was confirmed with similar data from Hamburg. I just wanted to point out this interesting idea from the discussion of this paper, in which Kolbel assures that maybe this difference in stiffness in the stent, using more flexible stent, could help us achieving better absorption of kinetic forces during respiration, target vessel angulations, and tortuosity. When planning these cases, please remember the hybrid stenting technique, which was deeply discussed in critical issues last week as well. In our center, we use it especially in challenging renal arteries, or whenever we are not sure about distal landing, so high angulated vessels, small diameter disease, whatever. I don't think that we need to talk about the technique, but it's important to rely, from my point of view, the entire branch, all the way from the branch to the ostium, in order to stabilize the target vessel. And finally, our experience. So we've used BVX quite a lot, more than 350 BVX. with a good follow-up of almost 30 months, with a good primary patency, 97%, just 11 occlusions, almost all of them in renal arteries, surprising low rate of endoleaks, 1%, and overall freedom from target vessel instability of 96%. If we talk about hybrid, this is the last slide. The mean follow-up is obviously shorter, good primary patency rate, surprisingly no endoleaks, although as I said, the follow-up is too short, and freedom from target vessel instability in this cohort of 95%. So just to conclude, GO's platform is of course a reliable option with proven durability in vitro studies and verified clinical evidence in multiple studies, as we just saw. The flexibility of BVX offers certain unique advantages without putting at risk the durability of the flood portion in fEVAR cases. In bEVAR cases, using self-expandable is an interesting option, especially in renal arteries or challenging target vessels. And my plea would be that please, we need 24 millimeters long BVX, and also developing a hybrid bridging stent could be a very interesting tool for future repairs. Thank you.
Thank you very much, Manuel, for sharing your experience with us. Quick reminder, any questions from the experts here? For the experts here, please don't forget that you can ask directly. So first question here, any technical implication in employing the stent in fEVAR cases, like avoiding to place the gap on the ring of the fenestration to avoid type 3C endoleak? Thank you. I think that's a very interesting question. So any tips and tricks specifically for fEVAR, because this stent was initially designed for bEVAR. It seems you showed great result in fEVAR now, but do you need to use it in a special way?
Yes, that's a great question. So we follow the tips explained by Timaran, a paper published by Timaran, in which he explains that in fEVAR cases, he tries to align the second ring, the second stent, at the level of the fenestration. We do it that way. It's not difficult, and results so far it's working well. Yes.
Great. Second question. Sorry, Arjan.
Can you explain how many millimeters of stent graft VBX you have inside the main body if you do it this way?
Yes, so around 8 millimeters or so. So every ring, it's easy to remind because every ring is 5 millimeters. So it's like 1.5 or so around 7-8 millimeters inside the aorta. Yes.
Yeah, and I think the good thing about these stainless steel rings is that even in obese patients, you can still visualize these rings.
Yes,
that's an important feature of the VBX.
That's true. Yeah.
Nice. Other questions? Thanks for a great overview. When do you also favor hybrid stenting in bEVAR? Long branches, dissected renals, CTD, question marks?
Yes, well, as I said, at the beginning of the experience, we used hybrid stenting, especially in hostile renal arteries. Then we moved on to use this technique also in other vessels with hostile anatomy, angulations, narrow anatomy disease, whatever. And we still do it that way, not routinely, but just in selected cases, yes.
Thank you. And this was a question from Roberto Aru from Philadelphia. So hi, Robbie. Nice to have you online. Said and Arjan, do you have any other questions from Manuel?
Yeah, I think it's just more of a discussion and question, because the hybrid stenting or the extension of the stent or the relining is ongoing topics. I think we all discuss it. There's a lot of subjectivity into what's a hostile renal. Do we find ourselves at a stage to decide this renal is a hostile enough to require extension, or this one is not hostile enough? I mean, we don't have really a one-way black and white. And I think you shared the experience about angulated renal. And how much angulation would you say is bad, and how much angulation is not bad?
Absolutely true, and a very interesting point, because in fact, when we study pre-surgery CT scans, you can maybe think that one renal artery is type B or type D, and you can think about using hybrid stenting, but then you go to the OR and you see another anatomy, because of course they kind of move. So it's not easy to tell. So at first, we only used it in type B and type D renal anatomies, very clear cases. But now I think that we are moving on to use it, well, selected cases, but more open-minded.
And Manuel, I just want to echo what you just said, also regarding the image you have in the OR and the image you have on the post-op CT scan. Don't forget when you shoot, and this is for the audience, your selective angio after stenting, that you might want to get your stiff wire back prior to doing that, because the stiff wire will actually make everything look good. Yeah. And once the stiff wire is back, you will have a kink. And so some of those patients need relining. And in my experience with hybrid stenting, the balloon expandable stent that is implanted within the self-expandable has to be implanted from the branch to the origin of the target vessel because of the flexibility of the self-expandable stents sometime and the visibility. Sometimes you don't see that it actually not kink, but has this kind of chicane going into the bridging stent. So do you do it the same way when you reline a self-expandable stent? Do you go inside the target vessel?
Yes, maybe just 2 or 3 rings inside the target vessel, but it's important to fix that self-expandable inside the target vessel. Yes.
Right, so great to see that we do it the same way in Paris and Madrid. So
well, yes.
If there's room, I have a completely different question about these. I was intrigued by these 100 million cycles of the bridging stents. How long is 100 million cycles?
Yes, it seems a lot, but if you read the papers published by Osterman, it's just around 5 to 6 years, so not so long. I have a question too regarding this topic.
But do we have to adjust our protocols, our follow-up protocols? Do we have to make more CT scans to check for target vessel instability after 5 years? How do we do this follow-up? Knowing that these stent grafts might tear or break down after 5, 6 years.
Well, at least in my center, we follow patients yearly with CT scan, but we lifelong follow-up, so we don't stop it.
Because I can imagine that in a fEVAR case, we stop CT scanning and we go on with duplex scanning. And if we see that the aneurysm shrinks, we are happy, but we do not know if the side branch is still intact. So when do we have to start then with a CT scan again in a shrinking aneurysm? I don't know.
I think it's very relevant what you just said is you can never stop follow-up.
No.
So maybe follow-up can be performed with ultrasound, and maybe a shrinking aneurysm is something that will make you feel good, and I agree with that. But then at one point during follow-up, and this can be at 5 years or 7 years or 10 years, if the aneurysm starts growing again, you need to shoot a CT scan.
Yeah.
I have a question too. So in our center, in fEVAR cases, we use BVX and we also use bFLAIR in certain cases. Do you think that maybe we should take into account life expectancy when choosing one stent or another, according to
Osterman's data
study? Are you worried about this?
So it's quite a challenging question because it is quite impossible to know exactly the setup of the research is different from the patient setup, and I think one of the key is the way you design your fenestrated on branch endograft. For the fenestrated endograft, is your fenestration is far from the origin of your target vessel. I think all bridging stents will fail at one point. Some at 2 years and others at 5 years, but they will fail. So the overall stability of the repair is very important. So I'm not exactly sure how to answer your question, but we have a lot of questions from the audience. So one question is, you mentioned the importance of the flare angle. In case of extreme renal artery angulation, do you recommend a double flare technique with the VBX to ensure long-term stability and prevent type 3C end leak? Can you talk about this double flare technique?
Well, I don't use it. So an important key point, as you said, is to make sure that when you're planning your cases, you need to avoid gaps. So that is an important point. If you avoid gaps, just leaving the 1.5 or maybe 2 rings inside the graft is more than enough, and just using 2 millimeters balloons, we haven't seen yet complications without using that double flaring technique.
But maybe it's good to explain what is double flaring technique. I'm not sure that it's clear.
I'm not sure. So I think that maybe it's using one balloon and then flaring it again with a wider balloon. No, maybe I
or is it pushing the balloon up and down so that you have a nice flaring? What is the double flaring?
I'm not aware of the double flaring technique.
I just wanted to ask.
It's not a French technique.
No,
so
it's not a Dutch technique. But,
I don't know if they. I think we have to here maybe highlight important thing, because it could be there's a perception that if you overinflate the balloon of the VBX, because it's semi-compliant, you can achieve a flaring effect. So you can make the 6 mm 7 without exchanging. I think possibly most of us, if we're going to use a VBX, we do it the traditional way. We'll go out, get out, go in again with a flared balloon and flare it. So I possibly I once they call it double flaring. I'll call it just flaring personally. But I wouldn't rely on the VBX balloon to do a flaring function, in my opinion. Don't know what you would think.
I think an important point is also the way you flare. In my experience, we tend to be a bit more aggressive than we used to at the beginning of the fEVAR experience a long time ago, is we get the flaring balloon slightly past the fenestration, because usually the origin of the target vessel is actually larger than the sealing point inside the target vessel, and to make sure that the bridging stent nicely adapts to the anatomy. You guys do it the same way?
Exactly the same way, yes.
Yeah, I guess we used to, when we used to do a fenestration with some gaps. But I think they don't do these fenestration with gaps anymore because we have alternative option.
There's a very interesting point. Someone asked, told me, thanks for the stiff wire retracting tip. No worries of a dissection that you see in the angio and then not having the wire in there. So great that you raised this. We actually replace the Rosen wire by a Terumo wire prior to shooting the angio. We do not retract the wire. We push a catheter, replace the Rosen by a Terumo. So thanks for pointing this out. That was a great discussion, and I think it's time to move on to Said's talk. Said will share his London experience with both the TAMBI and the VBX, and especially the low-profile new platform. Thank you, Said, for joining us tonight.
Great, thank you, and it's a pleasure to be with these colleagues. I think we've had really nice data today, and we've had very nice tips and tricks how to select the bridging stent and how to master and reduce complication. I think maybe time to talk about cases, what we all like to do and enjoy doing. And I bring two cases. One case which relate to a TAMBI case, which we were part of the FDA study about 4 years ago, and we did one case. And I think that's relevant to the VBX discussion because that's maybe the only endograft that has been examined with its own dedicated bridging stent in a formal study. So now we have the TAMBI available in Europe. I think it's important to talk about this one. We have not done a European TAMBI yet. The only TAMBI we had was this case, which was kind of FDA TAMBI. This is a 72-year-old female, who had some comorbidity, ischemic heart disease, hypertension, and also she has high cholesterol and COPD. She had a type 4 thoracoabdominal aneurysm measuring 60 millimeter. And I'll show you here pre-op CT. And as you see, a case included in a study has a really favorable anatomy at the time. And it's a typical type 4, no adverse feature, large target vessel, no extreme angulation. As you see, that's maybe we all agree if it is not for open repair, bEVAR would be the option because of the lumen size. This is the case, and I want to highlight for those who have not seen this, this is a branch device with a bridging stent dedicated for this branch device called VBX. This is the case and I'll show you kind of briefly just to remind everyone, we did this case at the time from upper limb access. You deploy the endograft, you open the top tip capsule, which allow you to access the branches. All the branches can be pre-cannulated, and then you start to advance the bridging stent. And in this case, you see the VBX stented in the renal arteries, and then you deploy the limb. And in this case, you get this final angiogram where you see the conformability of the bridging stent and or the endograft. And this was confirmed at the time with a cone beam CT to confirm that all the stents are in the correct position and rounded and nicely open. These patients have been under follow-up for 4 years and demonstrated really good outcome for this kind of intervention. The reason I mention it because now this is a CE approved, and we also have a CE approved VBX, which is approved for the use in a bEVAR. It is one of the lowest profile off-the-shelf endograft currently, and it has a shortest proximal aortic coverage above the celiac artery compared to other off-the-shelf options. It comes in a couple of sizes, and I think as a combination with VBX, it will offer us, as you see from the study that was reported in the US, the early outcome, I think, is reasonable and acceptable. I won't do many data here because I would really like to enjoy the discussion with you later about the technical aspect of the case. We have covered data enough, but there is also access available to these slides. You will see the 1-year outcome, which included 102 patients. This is very stringent study with a core lab examination and as submitted for approval. So all the data are very well scrutinized. And the main thing here from a target vessel point of view, if we move on to the target vessel here, to report the target vessel instability. We all worry about occlusion, restenosis, but also we need to be careful about other things like endoleak. And we talked about how to avoid type 1C endoleak, how to avoid dissection. When we summarize the outcome of VBX in 1 year in this FDA study in TAMBI, which included type 4 thoracoabdominal and pararenal aneurysm, we see the primary patency of the target vessel is 94.9. And when we look at each target vessel on its own, I think there's 1 celiac occlusion, 2 SMA occlusion, and the right renal patency rate was 91.8, and the left renal was 91.7. So when we think how we can use VBX in this first bEVAR on label, I think the message here, it is on label with its own bridging stent, so we can think that option is available to us. We also can think of this bridging stent might provide the longest available bridging stent until recently. Recently, we have other long bridging stent available. But I'll come to that point because different profile of different bridging stents are very important. Finally, I just want to finish my discussion about the TAMBI, that it's important to understand there are also other options like CMD, but what the TAMBI offer you immediate availability, but that at the cost of potentially more aortic proximal coverage. And there is some anatomical inclusion restriction, and also the advantage perhaps more for the appropriate emergency and urgent cases. Now, we have heard about VBX, we heard about the feature being independent stainless steel ring, the flexibility, the semi-compliant balloon. We discussed how we can use this one in practice, and we discussed the heparin bonding now, which is an advantage. But VBX has been around for a while, but until recently, we had access to the low-profile VBX, which is really interesting because it has impacted our practice significantly. Now, in addition to what we know about VBX in terms of the design, the conformability, the flexibility, and all these other things we've heard about, but we've noticed the trackability is significantly improved with the low profile. That's particularly relevant in our practice because we often do these procedures from transfemoral access. And the trackability and retention of the stent is a key for the success of these procedures. So what has changed in the new generation VBX? It does have approval for bEVAR and fEVAR. It comes as a long expandable stent graft up to 79 millimeter. And I think the flexibility of the delivery system, in my opinion, is much better with the new generation because it's softer and nicer. And the most important, the profile. And the profile 6 French is relevant because particularly when we do a steerable femoral access, this is something that allows us to go through a smaller steerable sheath. This is what's different here. If you look at these slides specifically at the old design and the current design, I think you see how the smooth transition between this bridging stent and the balloon delivery system. And I think this is maybe was a point where I thought this is a kind of a game changer from before, and I start to think about it, how could the track and help me in a difficult anatomy. So I mentioned the change in the profile, and I think for bEVAR, 6 French and 7 French is significant change to us. Many of our steerable sheet are 8 French restricted, and 8 French, when it is bent, become almost 7 French. So it's important to kind of bear in mind in these. One thing to highlight, the 10 millimeter and 11 millimeter VBX has not become on the low profile yet. So we're still waiting, and we're hoping this will become soon. I think this is been discussed in terms of the patency. I will not go through this. I will go through a final, maybe a case to show you how the low profile bridging stent helped. This is a patient who had is 64 but has some comorbidity, had stage TEVAR and a bEVAR in a very hostile anatomy of type 2 thoracoabdominal aneurysm. His celiac was occluded preoperatively, and on follow-up 4 years later, his bEVAR migrated with a significant type 3 endoleak between the TEVAR and bEVAR and significant SMA kink, which is in these patients with comorbidity, the only solution to try to fix it endovascularly. And he relies on these SMA significantly. So in this case here, I show you some anatomy, and that's what I meant by hostile, specifically the descending thoracic aorta, which made it very difficult to kind of maintain the overlap between the different endograft, and also to achieve a reliable access from the upper limb. So you kind of restrict it to a lower transfemoral access in these patients. This is his pre-op and post-op demonstration. And we had in this case this a bEVAR graft which has migrated down, and we have a type 3 endoleak. In this case, the bEVAR graft proximal length was not very long, and you would have hoped it would be longer, but you see the amount of this SMA kink, and it's not fractured, but it's very badly kink. And my concern here, will we be able to track any bridging stent to reline this stent? So considered in this case, we know the celiac occluded, so we know the SMA is very precious. We know we have multiple aortic angulation. We have maybe only one route to get in, maybe. We know the SMA is very angulated and stenotic, and we want something that tracks really well. And we like to use a steerable sheet because it's really difficult to come from the arm through this access. So the operative plan in this patient was to get access, get a dry seal from below, deal with the disconnection first. We use a C-tag TEVAR here for the type 3 endoleak, and use endo-anchor, which I don't often use, but just to ensure that this does not move again. And eventually we cannulated the SMA using our standard technique for the steerable, which is 16 French aptus with an 8 French inside it, and managed to open the SMA with a balloon initially. And finally, we tracked VBX. And I was very concerned whether this VBX will track or not. And I'll show you here maybe some videos, and this is how, through the kinks, I think it was good to see something with a low profile and smooth access who helped this case and helped this patient. And I think this is, to me, is a demonstration how the low profile can add to our practice. I mean, the number of options and different bridging stents, that having more than one option can be very useful for certain cases. So my take-home message here about the low profile and new VBX, I think the tracking is my favorite, is perfect. It's really appropriate for transfemoral steerable access, particularly the long one, where you cannot really easily track transfemorally any other long bridging stent with a certain sizes. The retention on the balloon on the new delivery system, in my opinion, is much better, much improved, and I would like to hear what the other expert view here as well about this one. And I think that's maybe because of the design change, and there is no step between the delivery balloon catheter and the stent. Thank you.
Thank you very much, Saeed, for sharing your experience. Can you clarify this new low-profile platform? The stent hasn't changed, it's just the shaft and the balloon? Is that what it is?
That's my understanding, yeah, the shaft and the balloon. Yeah.
Okay, but it's the same stent?
Yeah.
Okay. You showed nice images of cone beam CT. In your practice, do you routinely perform cone beam CT after fEVAR and bEVAR?
So, reality, I would like to in every case, but I don't think I like to have a new and better imaging facility to do it. So my current system may be good if on a selective cases. But I think in 2026, if you have access to a modern technology and if you have access to a modern machine, I think it's a very useful thing to do. And it will change the follow-up and the way how you discharge hospital. So in a way, it will save money. But we have to work within our resources at the moment. Yeah.
Now, in our practice, shooting a cone beam CT has significantly reduced the need for secondary procedures because you can spot any issues right away and fix it. And exactly 100% in line with what you said, it's really reduced the hospital stay. We don't need to shoot a CT scan before discharge. They've had the 3D imaging. We shoot just an ultrasound, and then they are discharged very soon. We see them a couple of weeks later with their first post-op CT scan. Is it the same for you guys?
I want to do you do CT angio, cone beam CT angio, or blank?
So it depends on the renal function.
Okay.
If there's no issue regarding contrast injection, we would do a cone beam CT with injection, and so it's a double spin, so we can have both injected and non-injected. If the patient has a kind of borderline EGFR, which are most of our patients, we would just do an AP angio with 20 cc's of contrast and then do a non-contrast cone beam CT.
Yeah, we were hesitating about doing these CT angios at the end of the procedure because usually, well, they already had quite a lot of contrast, and then doing the CT angio cone beam, which gives them another 80 cc of contrast usually. It's quite a lot. So, but we tend to do more blank cone beam CTs after the procedure, and it's really helpful. Yeah.
Manuel?
Yes, we use it always in every fEVAR or bEVAR, non-contrast cone beam CT, just looking for structural issues. Always, yes.
Yeah, it really makes sense. So, what issues do you encounter with cone beam CT during the procedure? Well, I think I hadn't read that question before asking you guys, but again, we're looking, especially in fEVAR, when we're going up and down with various devices, and you can have a conflict with the stent protruding in the aortic lumen, and sometimes with the AP angio, you miss a stent that has been crushed by a limb advancement, a sheath, or the steerable sheath going into another target vessel. So I think it really makes sense. Do you guys have other questions for Saeed regarding his experience?
How do you see the TAMBI when you compare it to the other devices that we have?
Yeah. I think
one of the great advantage, I think, is that it might be a kind of off-the-shelf device for acute cases. And we have other devices for acute cases as well, but it looks good for acute cases.
Yeah, I think it looks interesting. In Europe, our experience is very small with TAMBI to be able to determine how it's going to fill a space in. I can see things. I can see the low profile. I can see the proximal coverage shorter. I can see that you can restrain the mid-segment of it to allow access to a narrower, potentially target vessel. But what I don't yet know how we're going to really be using these, optimizing outcome. I don't know how we're going to try to get closer to the renal arteries. There are techniques to do this. So I think we probably next year I will answer this question when I have a little bit more experience with it. But at the moment, I think I don't have.
Arjan, do you have a large experience with TAMBI?
Not yet.
Not yet.
No, they're coming next week, the guys from Gore, to show us the device. So probably this year.
For a long time in Europe, we've been spoiled and we had access to all those devices before the US and the rest of the world. But fortunately now it's going the other way around.
It's very exciting. I mean, to have the option to treat more and offer more treatment, I think it has to be a good thing. We will need to feel it and practice it.
And do you think that the policy from Gore will be that the TAMBI will promote it together with VBX or with Viabahn? What do you think?
I don't know the answer. I mean, to me, I would follow what the FDA study have been doing. I will also follow my own practice, which is I have been using balloon expandable stent as my main bridging stent, and the results have been good. I acknowledge the other school of self-expanding stent and hybrid stent and all these things, but I think I'll use VBX for now.
So I have questions regarding TAMBI in pararenal and type 4. Some concern about the results in the pararenal and type 4, much more favorable in type 1 and type 3. Why do you think it underperforms in pararenal and type 4? And looking at the literature you've shown, is this something that was of concern?
I think that definitely we don't actually exactly know, but I have been talking to some colleagues who've been involved in this one. I think the complex endovascular branch repair has a variable experience in different parts of the world, and I think in Europe we have been using branched EVAR for a while. But well, we need to wait and see. I think results possibly will be better than what we have seen before. And you've seen most of the Embrace and other study, everything about over the 95%. So I think we have to be optimistic and see. But I don't have explanation why.
No, but really, I think it's about selecting the appropriate patient, graft design, bridging stent design. Don't push the envelope. I mean, there are good and bad cases for each devices. Time is almost over. I mean, time is flying with you guys. Your talks were really very interesting. I've learned a lot. Thank you so much for sharing your expertise and large experience. It's been a pleasure to host you on this PVI webinar sponsored by Gore. Thank you, Gore, for organizing this session. And don't forget that this webinar will be available on our PVI OnLive, which is our website, early next week. Thank you very much for attending, and have a great weekend.